brainstem death and the change in goals. The initial phases where there is a severe brain injury patient comes to you, I think the goal of the ICU is predominantly in securing everything, maintaining the perfusion, maintaining the airway and breathing, and definitely with regards to the brain, the raised ICPs, there are in n number of measures, the medical measures, the surgical measures to attempt and maintaining a cerebral blood flow and cerebral perfusion pressure. So once the ischemia spreads, with regards to the entering the brainstem, where we have the pons, the medulla, and ultimately ending the spinal cord, the multiple physiological changes happens. So the shift, or if you look at the treatment goals or the change in goals, the initial treatment are completely, and it is more focused and directed towards recovery of injured brain. So once that process reaches a stage where an irreversibility sets in and we are moving towards a possible brain death, then the shift changes. The focus switches to more of a cardiopulmonary and metabolic resuscitation of a potentially transplantable solid organs. And if you look at the physiological responses in a patient with a catastrophic brain injury, the ischemia, once it starts distributing from the cerebral cortex to the spinal cord, things changes. All of you must have seen this, you must have heard about it, must have seen it in your practice, where the increased vagal activity is the key when the main physiological response in the cerebral activity, where the heart rate, BP, and the cardiac output decreases. Once it reaches the pons, we have a mixed vagal and sympathetic stimulation, the Cushing's response, what we normally call it as, where the blood pressure goes up, heart rate comes down, irregular breathing. We may act something to recover this. So once it moves forward to the medulla, where the sympathetic stimulation hyperactivates and what we normally call as an autonomic storm, where there is a severe, hemodynamic and fluctuations do happen. The heart rate increases, the blood pressure goes up, and we will have hypothalamic destruction, where there is thermoregulatory impairment and associated with a pituitary dysfunction causing endocrine dysfunction. And once that ischemia reaches the spinal cord, then we have sympathetic deactivation, where severe hemodynamic instability with decreased heart rate, cardiac output, and hypotension sets in. So the cardiac and the pulmonary intermingles each other, the responses. In initial phases, when there's a catecholamine surge, the SVR goes up, the cardiac output drops down. But when there is a decrease in the sympathetic output, once it reaches the spinal level, probably the SVR decreases, resulting in venodilatation and myocardial contractility decrease, subsequently resulting in decrease in the preload, hypertension, and decreased coronary perfusion, and myocardial contractility is affected, ECG changes, and other things started to come in. Only less than 50% develop left ventricular systolic dysfunction. Coming to pulmonary, the autonomic storm itself and the cardiac dysfunction can cause pulmonary dysfunction. Increase in the systemic vascular resistance results in increasing left arterial pressure, and which results in increase in pulmonary arterial pressures, and which ultimately alters the hydrostatic pressure and systemic shunting, resulting in destruction of pulmonary capillary integrity. Catecholamine storm can directly causes damage, and other inflammation like villi or other things can again mediates the acute lung injury. So an ALA pattern develops in the pulmonary. The renal, the sudden fluctuations in the BP, ischemia perfusion injury associated with inflammatory infiltrates causes trouble. Along with that, when the posterior pituitary failure, the cessation in the arginine vasopressin production, resulting in central diabetes insipidus, the hypovolemia affect hemodynamics, and hypernatremia both can be detrimental. Coming to the liver is almost tolerant to periods of ischemia. But the inflammation and prolonged hypernatremia can affect the organ dysfunction, can affect the organ with regards to liver function. Endocrine dysfunctions, pituitary failure always happens. Anterior pituitary may be less predictable. Posterior pituitary, where we have the ADH and AVP, decreases rapidly, ending up in severe hemodynamic fluctuations because of hypovolemia, polyuric phase, and then electrolyte abnormalities, noted being the hypernatremia. So if you look at the clinical pathways of an organ donation from a catastrophic injury, after the injury, the initial phase is advanced ICU management and neuroprotection. But once the deterioration starts, despite your measures, the ongoing neurological deterioration, then we have the corning and refractory ICP. Then we have the cessation of brainstem reflexes, and brainstem diagnosis is made. Then comes the discussion for organ donation. In between, the pathway can be a little bit take a deviation when there's an ongoing neurological deterioration and end-of-life things has been discussed. Probably you can opt for an organ suitability plan, and if suitable, plan for organ donation. If it is not suitable, the exodus happens in a natural process. If you map the journey, The critical pathway of disease donation, the same sequence of events started. The brain injury, the ultimate aim always is advanced ICU management to get the brain reversible to a normal physiological and normal CNS functioning. And that is failed, and the ongoing neurological deterioration is happening. Corning or refractory ICP is happening. That is a time probably a possible donor can be thought about, because devastating brain injury medically suitable for an organ donation. And then when it reaches the next stage of a cessation of the brainstem reflexes, we check neurological status every day in the patient. That is a time the term called as a potential organ donor has been mentioned. That means a clinical condition suspected to fulfill brain death criteria. Once the brain death is diagnosed, it is an eligible donor, where medically suitable person declared brain dead and neurological criteria is an eligible brain dead donor. When it comes to the organ donation, you have the actual donor consented, where incision is made for recovery, utilized the actual donor from which at least one organ has been transplanted. The intensivist. This process of its organ donation is a very tedious process, where you diagnose brain death, identify potentially brain dead donors, medically manage the organ donor, and procuring organs till it reaches the recipient. It needs a full integration. So intensivist is a decisive role in the donation processes. It is a very crucial role, coordinating everything, managing a same like an sick ICU patient, and this requires definitely a training, and the other demands of the other critically ill patients, it can definitely get compromised. So probably the unit or the intensivist needs to dedicate at that point of time, especially to the particular system, till it reaches a final conclusion. ISCCM position paper 24 recommends that trained critical personnel be involved in the management of potential organ donors. Early identification, assessment, and maintenance of potential organ donors is a key, and intensivist plays a vital role in evaluating a deceased donor also. So these three things, definitely an ICU person or intensivist in charge of an ICU can definitely take it, whichever ICU they belong to, medical, surgical, neurological, anywhere these kind of things can happen. So there are three steps to the process. One is the early identification and evaluation. In early identification evaluation, it is a framework for the complex process. So the success of any donation process requires that a potential brain dead donors are detected and are referred, or it has been taken care by a professional responsible for the evaluation and conversion to actual donors. For this, ABC approach is definitely worthwhile to consider. A stands for the etiology. The key requirement is knowing the cause and irreversibility of the neurological injury, which is necessary for considering any patient as a potential donor. If you want to elaborate further, failure to determine the etiology of brain damage precludes the diagnosis of brain death. If an anoxic encephalopathy following a cardiopulmonary arrest, the primary reason for arrest, if it is a coronary artery disease or a drug overdosage, must be investigated before you come to the conclusion. Brain death alert is something which needs to watch about. The core objective without this kind of approach is that you identify a potential donor as early as possible. The point of controversy always exists when to start this process. However, the system 1 and system 2, if we take both, system 1 is a process after a brain death has been diagnosed or strongly suspected. System 2 is that referral occurs before a brain death diagnosis in the context of a devastating brain injury or the brain death is imminent. The conclude is that early referral is crucial for optimizing medical management throughout the process. Nothing else. It is basically to optimize medical management. And please note, a donor is not eligible until a brain death is legally certified. The prerequisite, all of you know that. I'm not going to details of it. We have all the three things. And then there are certain preconditions and confounding factors needs to be ruled out. Please note, the confounding factors can be any of these things: shock or hypertension, hypothermia. If it is a snake envenomation, you need to think about it. Brainstem encephalitis, GB syndrome, and severe hypophosphatemia, encephalopathy, and any drugs a patient is on to alter neurological, neuromuscular, and EEG tests like anesthetic, neuromuscular, the GABA, and neurologic should be taken into consideration before you go ahead with the procedure. And the C, in the ABC, the C is that the checklist should be there at the bedside or in the handy to confirm that there is no contraindication to donation. Because if the process is started and suppose the professional has to come from outside, the resources is mobilized, then the contraindication has been coming up is not a right thing to do it, because it's a very tedious process. So that needs to be considered before we end up on it. After the step 1, we go to step 2. How about the proactive donor management? The common physiological changes in the brainstem death with regards to the frequency is hypothermia first, more than 100% develop that. Hypertension, various reasons. Diabetes insipidus, arrhythmias, pulmonary edema, DIC. Almost all the complications what you see in an ICU patient is there when you talk about the brainstem maintaining patients. And this particular thing, the countering the autonomic storm, because of massive adrenergic activity when the brainstem is affected, resulting in the wide range of physiological verification. Please note that up to 20% of organs and a large number of potential brain dead donors are lost because the clinical management is challenging and if you not properly manage this patient in this particular context. So again, a checklist or an approach like what has been the mnemonics VIP approach must have been, intensivists must have heard about this approach when you talk about circulatory shock and septic shock. With regards to that, in maintaining a potential organ donor, we have something called as a VIPP approach, where V stands for the ventilation, because you provide adequate oxygenation, which maintains the oxygen saturation, the CO2 is maintained. And when you have then we have three important physiological things: the preload, the contractility, and afterload. Where preload is low, we give fluid infusions. More output is more, you give desmopressin. I'll come to it a bit later. And if the contractility is affected, LV dysfunction, temperature has to be maintained more than 35, make sure that it is maintained. And then if it is still low, then consider inotropic agent like dobutamine and consider endocrine replacement like your thyroid hormone replacement. If afterload is affected, severe vasodilatation, consider vasopressin and other vasopressors. Steroids also needs to be considered. Where ventilation takes care of the oxygen saturation, the other three, the infusion, pumping, and pressure takes care of the cardiac output. Together, we can maintain the oxygen delivery to the important organs. Now, this is a VIPP approach from the ICU position statement. You ventilate safely, like any other ICU patients with a PCO2 of 35, PO2 target of more than 100, make it a little bit high, maintain the pH normal, and you can use ECMO also to maintain an organ donor. Central line, arterial line should be there. Other measures of assessment should be there. If it is an instability is there, consider three possibilities. Hypovolemia is being diagnosed with your gadgets available, or clinically you need infusions. Aggressive fluid resuscitation. You have your pulse pressure variation, arterial line, which monitors can give that. If it is more than 15, you give fluid to repeat back to the normal. If there is a diabetes insipidus, consider giving vasopressin. With regards to cardiac dysfunction, I mentioned earlier, temperature has to be maintained to more than 35. And then if still cardiac function is low, then catecholamine can definitely cause severe myocardial depression. Sometimes myocardial things can happen. So consider using dobutamine and then hormone replacement therapy like L-troxin and thing. And ECMO can be considered to maintain. If it's a severe vasoplegia, vasodilatation, and you assess the fluid, if you find that the fluid assessment is not fluid responsive, ppb less than 15, consider vasoconstrictor agent. Vasopressin in a higher dose, a peak shock we give up to 1.8, up to 2.4 units is a key. And then subsequent to it, you can add norepinephrine, adrenaline, and also consider if still unstable, hormone replacement therapy with steroids also can be considered. The primary target, like any other ICU patients, MAP is 60 to 65. If donor is hypertensive, maybe MAP to be kept at higher side for good perfusion. Your urine output is another key, should maintain 0.5 to 2. More urine output is also very dangerous, that I'll come to it a bit later. Oxygenation, 70 to 100 millimeters of mercury, maintain the pH. Blood sugars, insulin infusion should be on board to maintain 120 to 180, it's very key. And HP, any other sick ICU patient, the target is 7 gram per deciliter, maintain that. But if there is hemodynamic instability, organ dysfunction, hypoxia, consider keep a higher trigger, 8 or 9, you can keep it. Temperature, again, hypothermia is very common, 100% patient develop hypothermia. So maintain core temperature of 36 to 35 with your warming devices. Sodium, again, is a concern. Always hypernatremia with regards to diabetes insipidus is going to happen. So maintain sodium around 135 to 155 and potassium around 4 and 5. Ejection fraction may be a bit less, but 45 you can definitely maintain. Carbon dioxide at a normal level with a cardiac index of 2.4. So an optimal level of targets should be maintained in a potential organ donor. With regards to hormone replacement, initial fluid resuscitation and vasopressors, if you fail to achieve stability, thyroxine, we have oral tablets available, but IV in some centers it is available, but not very common. 300 to 400 microgram through Riles tube can be given. Even though the absorption kinetics can be difficult situation in an unstable patient, but still you have to give it. Steroids, methylprednisolone 15 milligram per kg per day, maximum 1 gram per kg. And if there is a diabetes insipidus where urine output is more than 4 ml per kg, sodium is going up, osmolality is high, then desmopressin needs to be considered to be given 10 milligram spray each nostrils, total to 20 milligram, 2 doses. Electrolytes, sodium remains a key. Hypernatremia, Of course, the liver transplant, the recipient cannot receive the liver if hypernatremia maintains more than 150. If more than 150, you have the dextrose. 145 to 150, you can alternate between dextrose to half normal saline. 140 to 145, half normal saline, NS alternatively. Less than 145, as any other patients maintain with a normal saline or ringer lactate. And now this is a particular study published in Transplantation 2016, a checklist, a bedside checklist adapted on the VIP approach, and they tried to implement as a quality improvement in 27 hospitals over 24 months in US. And the results is that the reduced cardiac arrest, adherence to the goal list, was associated with the reduced odds of cardiac arrest episodes in a potential organ potential organ donor patients. And the organ yield was also very high. Number of organs harvested and transplanted was very high, and a checklist has been maintained. We need further research to confirm this kind of checklist approach in any patients. However, some sort of a protocol is always good. Step 3 is optimization of donated organs. The time frame, which earlier is the key, but something called as a wait, treat, and see strategy. The core idea is that a longer period of donor treatment is not detrimental and sometimes be beneficial. The goal is to increase the organ availability and preserve long-term graft function. So heart and lungs, even though initially seemed unsuitable because of the autonomic storm causes a lot of trouble, may sometimes can become viable for transplantation if the donor treatment is prolonged for hours. So an active wait, treat, and see or relax or repair strategy has been suggested, not proven, to increase the number and quality of kidney and heart transplantation, because the LV dysfunction, if you look at the evidence of these things, the cardiac recovery, even the initial phase of autonomic storm, you develop severe LV dysfunction can be seen. After 48 hours time, there's a slow cardiac function can recover and it has been shown in a serial echocardiography finding. So hearts with their transient LV systolic dysfunction can be successfully resuscitated and transplanted without an increase in recipient mortality. Evidence of other organs, not very good as the cardiac, can be expected in lung and abdominal organs. Acute kidney injury with tubular necrosis is not an absolute reason to discard organs, because recovery can happen. The key is that the multidisciplinary imperative, the communication, collaboration, and care. The ICU team, or the ICU physician, ICU team, the entire team is in the central of the point, with the family and the procurement surgical teams on the side, and a multidisciplinary imperative and a good communication collaboration is the key. With the families, communication requires training and should be stepwise. Please note, an important point is that the discussion of donation should be or must be decoupled from confirmation of the death, where family must understand and accept death before donation is explored. So the decoupling of a brain death confirmation and a discussion of donation has to happen in ICU, and that is a key in discuss with the family. Between teams, an excellent communication between the ICU, operating room, and the procurement organization is necessary. Of course, we have to inform our nodal agencies, and every guidance will be given by the nodal agencies, which is a beautiful system which have been implemented in our country. And coordinating between departments is a key. For example, with regards to fluid management, nephrologists who's taking the organ might require a more fluid, and a pulmonologist who the lung has been interested must require a less fluid for decreasing lung edema. This is a normal thing happens in the ICU. So a coordinated management, discussing with them, and the team discussion how to maintain is always the key in maintaining it. Supporting staff, the process can be meant physically, emotionally draining on the staff, because this is a very, very extremely emotional thing to happen. And a debriefing section after each donation episode is highly useful for learning and for supporting staff members. So the second last slide, which I would like to put, is that the Roberts rule of, which is published in NEJM 2013, the dead donor rule. Patients may become donors only after death, and the recovery of organ must not cause the donor's death. That is one key thing which always, the intensivist should keep in mind when you consider these kind of things in your unit. So the key points before I conclude, in the management of a donation after brain death in ICU, the success of any donation process requires that a potentially brain dead donor are detected and referred either to a team which is taking care of an institution, or an intensivist in the same team who is taking the lead with other team members early. Adoption of protocol and checklist may improve the process of donation after brain death. Early institution of appropriate maintenance strategies is fundamental to increase the number and quality of organs for transplantation. Proactive interaction among intensive care team operating room professionals, and transplant coordinators is essential for a proper donation after brain death management. The intensivist is the key, plays the key role in the organ donation process. That is something which definitely an integrated approach with good communication and a good care and a proper protocolized approach definitely will help us in moving this particular donation after brain death forward in most of the centers in our country. Thank you so much for the opportunity. Thank you so much for a patient listening. Over to Dr. Saurav and the panelists for further discussion.
Thank you, Dr.
Thank you very much, sir. Uh, this was an insightful and extremely practical presentation, and your clarity on the physiological nuances and workflow integration, it has set a perfect foundation for our panel discussion. So I would like to invite Yash Javeri sir and Sunil Shroff sir for the panel discussion. And the first question is for Yash Javeri sir.
Yeah.
So, sir, when the family is still processing the catastrophic brain injury, so what structured counseling approach do you recommend to introduce brain death and organ donation more sensitively?
Yeah. Thank you, Dr. Saurabh. And the stage has already been set by Dr. Jacob, so things are easy for me. This is very catastrophic situation. Most of the brain injury, especially in the younger patients where we are trying to harvest organs, is a catastrophe. It's a sudden medical emergency for them, and they have not come terms to the situation most of the time. So we have to be slow, but yet time bound. We cannot take ages to decide. We have to have a tiered approach. First thing is to tell them that there is a catastrophic brain injury, whatever it is trauma, intracranial bleeds, super refractory status epilepticus, whatever has caused brain death. Once the concept of irreversible brain injury has been understood by the family, then we go to the second step, which is introduction to the concept of brain death as death. That is again equally important. At times, this has to be time sensitive, repetitive, and we have to have multiple stakeholders together, senior person, social worker, and who else. Once now they understand irreversible brain injury, concept of brain death as death, then comes the final question, which is they get introduced to the concept of organ donation. So it has to be a tiered approach. We have to be slow, sensitive, steady, in a multi-tiered approach. The counseling has to be on multiple occasions. It should be a very calm, empathetic counseling. We should not be pushing them to the decisions, and there should be unison. Unison in understanding of the treating teams, the neurologists, neurosurgeons, intensivists, whoever is involved, and the family also should be at the same platform. If there is any confusion, we have to sit on the table again and make them understand better. The most difficult part is obviously the third part. Many a times they understand irreversible brain injury. With great difficulty, they will understand the concept of brain that it's still a challenge in most of the country. Now, the third part is the most challenging part, where we need multidisciplinary counseling and all the stakeholders, the organ donor specialists, the coordinators, at times neurologists, at times the social worker, they have all to pitch in so that the family is counseled at a very disastrous moment for them. Thank you, Dr. Saurabh.
Saurabh,
Thank you very much, sir. That
yeah,
was extremely practical and deeply
Yeah.
empathetic answer from your side, sir. Shop,
Saurabh,
sir, you want to tell something, sir?
yeah, I mean, good job, great job, Jacob, first of all. And I'm so delighted to know that you were in Ramchandra when, you're doing your student days and you've taken this program forward when you've become an intensivist. So very
Thank
proud
you.
of you.
Thank you
And
so much. It's a real honor to listen from you like that. Thank you.
I want to add just a couple of things to what already, you guys have done an excellent job. And I like very few intensivists talk about decoupling. And I liked what you said, Jacob, that you need to decouple. And that's very important. You can't talk organ donation and brain death together. First, acceptance of death is very important.
Absolutely.
And as Yash said, that you need a tired approach to counseling. One of the things which we need to realize as doctors when we're counseling is to understand the stages of grief. Grief have 5 stages, and people go through these stages in a different timeline. And when there's a young death, Then there are stages. The first stage is denial. It's not possible. The next stage will be anger. Why did it happen to me? After that, you'll get a stage of bargaining. Can you get another doctor from somewhere else, perhaps, who can look after me, look after my loved one? And then there's depression. They'll just become very quiet. And after depression comes acceptance. So we are, as intensivists or as MBBS doctors, we're not taught all the stages of grief. Even when you're doing normal counseling on a very, some patient who's very serious. So if we understand the stages of grief, the first reaction of the family is always going to be no to donation. So you have to be very sensitive to that. And believe we have a talk in our foundation where Pallavi talks about no is not a no problem donation. No is the first reaction you speak to the relatives. If you continue to support the relatives in their decision to donate, many of those no's will become yes. So please remember that in your conversations with the family. And as I said, if you have a family who knows about brain death ahead of time, who's already been educated about it, it is so much easier to counsel the family. Now in Tamil Nadu, where we did 268 donations last year, many families are aware of brain death. So counseling becomes a lot easier. And in 10 to 15% of instances in Tamil Nadu, the family comes forward and says that we want to donate organs. And that becomes so much easier for everybody in this kind of field. So I just wanted to add that. And one more point I wanted to add to your slides, Jacob. Everything was fantastic. The cutoff point for sodium, we take it as 155.
Okay.
155 is acceptable. Some units will also take up to 160.
Okay.
But if you take 155, it should be all right.
Fine, sir.
This is what I wanted to add, Saurabh, but excellent job. Keep going.
Thank you, sir. Thank you for your expert comments. Your teachings are always impactful, sir. Thank you. So, sir, Shroff, sir, the next question is for you only, sir. So, from the retrieval surgeon's perspective, sir, what essential clinical information do you expect from the ICU before you arrive to avoid the last minute organ rejections or cancellations? So, what are those essential clinical informations that you expect, sir?
So, the number of hypotension episodes, whether, what was how hemodynamically stable was the donor for the last few hours, what is the urine output, what is the creatinine at the time of admission, and what's the time of creatinine now, before you actually, decide to take the organs, and family said yes. But many of these patients get acute kidney injury and have a high creatinine. So if there's a young patient with a baseline creatinine, normal, and then at the time of retrieval, for some reason, maintenance may not have been good, the creatinine has gone up, you will still accept the kidney. So you need to know the creatinine at the baseline and that time. So you need to have a checklist again. The checklist concept is very good. In the checklist, you need to know their virology status. You need to know their blood group. You need to know the urine output for the last few hours, what it has been. You need to know the hemodynamic status. Yeah. And then, you need to know, obviously, blood group and so on. And also, you need to ask specifically that whether they have, like rabies. I'm just giving example. Have they had a dog bite exposure? These are, because in India, many times it so happens that somebody may have had a dog bite, 5-6 days before they had a head injury. So all these questions are very, very important to find out so that there's no missed kind of, episode which happens afterwards. And also whether the patients, whether the patient has been, has had an infection, sepsis, all that needs to be taken into account. What are their liver function tests? What has been the cause of brain death? Most important. It should be, a known cause of brain death. It should not be, if there's a metabolic cause of brain death, if there's due to overdose, as all those things, then you have to be extremely careful in, whether, the brain death has been properly diagnosed or not, two certifications have happened or not. So all that information needs to be transmitted to the retrieval unit before they come on scene. If you're taking the heart, they may want an ultrasound. If you're taking the liver, they will want, definitely they will want to know if they have done an ultrasound, if the liver is fatty. In Kerala, for that matter, I'll tell you, many livers are fatty and we're not able to take the liver. because of alcohol problem. And then there is also NASH, which is now more prevalent. So a liver surgeon will need something else, a kidney surgeon will need something else, a lung surgeon will need something else, a heart surgeon will need something else. So depending on what organ you want, the questions will change, but basic questions remain the same. Are these things done? And then you should also make sure that there's either if you need to do cross match, the serum is available. So that the cross match can be done. Many times, what happens that the blood is not available. So you are not able to do cross match. So as a surgeon, you are the captain of the ship, and you should make sure that the idea is that the organ should work in the recipient after you transplant. You need to give success stories in India.
Sure.
So you need to make sure that all these check boxes are ticked and everything is in the right place before you accept an organ. Thank you.
Dr. Saurabh,
Thank you, sir.
one
Sir.
point is taken.
Yes, sir.
So, as a
Sir.
responsible intensivist, it is our moral duty that we give everything packaged administratively, legally, as well as clinically optimized patient. Once the retrieval team is there, there should be no scope of failure at any of these levels, whatever it takes. So, it is
Yes.
our obligation. Thank you.
You know what happens in many situations? There's a late identification of brain death. And as a result of which, what happens is patient's blood pressure has dropped.
Mm.
Then the patient has had some acute, kind of injuries, especially the kidneys. And so that is not uncommon. So late identification certification leads to, poor maintenance. They can't help it. And sometimes maintenance is very poor. So in early days, a unit, when it's certifying brain death, you have to be a little bit extra careful. You need to have a senior intensivist. You need to have some mentoring done, perhaps by somebody else who has done brain death certification and maintenance, so that the whole, as Jacob said, once a devastated brain injury is diagnosed, and it's a potential organ donor, the whole management shifts towards the recipients, the organ working in the recipient. A neurosurgeon will not like fluids to be given because they feel the edema of the brain will happen. So they're very conservative with fluids. So many patients who come from neuro units come with a very low volume of fluids. So you may need to pump in fluids like crazy to get them hemodynamically stable. And we've seen that many times in our practice.
Thank you, sir. So you have highlighted exactly how the ICU surgical coordination it can improve the outcomes. Thank you, sir. So coming to Jacob, sir. Sir, in your ICU experience, what early clinical triggers should prompt intensivists to alert the donation or the transplant team for a potential DBD donor, and how can hospitals standardize these, sir?
That's right. The ideal way should be there should be the name sounds quite difficult because there should be a coordinating unit. You can call different name. Don't use the word transplant or organ donation unit. It's a coordinating unit because that term can be difficult and that particular team or a person should be alerted and he should be getting the information from the ICUs, neuro ICU, surgical, wherever, or the multidisciplinary unit where what the different donor names have been mentioned. Certainly that this kind of particular patient has got a devastating brain injury, which could be a possible thing. I think the thing starts from there. My point of take is that maintaining is as good as taking care of a patient who wants to get recovered. So these two, if we go aligned together, it's both the same. And then the process, like Dr. Yas mentioned, the tired approach will continue. So we are maintaining the treatment as a patient, not as the concept of giving the decoupling of it starts from there. Not that you're going to, the family in your mind also, it is like maintaining a particular person so that the organs have been metabolic. I mean, the metabolic and the organ association is happened from that level. So that is a trigger and that is a daily process. It is not something which happens. It is a daily, that is what some nodal agencies have given an instruction that every brain death needs to be documented. But in reality, it may not be happening. So that the trigger of everything starts from that thing. And then when it comes to a term, you call as a potential brain the donor, and then everything switches towards the kind of resuscitation. Then comes a tired approach that Dr. Yas mentioned, and Dr. Sunis has mentioned everything. That process has to combine together. The counseling of the family, the taking care of the particular maintaining of organ donor, and then ultimately end up in a thing. So the trigger has to be started early, and the team should not be called a transplant team or organ maintenance team or anything like that. It should be a
Yes,
ICU
yes.
team where they take the things forward.
Many units will say that at a GCS of less than 5 is your trigger to make sure that this could be a potential donor. So if you have some standard protocols in the ICU for identification of potential donors, and if there's a nodal officer in that ICU, what Spain follows, our donation rate will go up because not everybody is tuned to brain death and organ donation. So what we are proposing even to NOTO is to have a nodal officer in every ICU who happens to be a doctor who take charge of organ donation and brain death. And there needs to be those triggers. That's a very good question, sorry you asked. Those triggers are very important, and these triggers have to be very simple. And if I remember, there's something called GIVE also in the same thing, GCS of this much, and this is, all ventilation, and everything is included. Just like you said, VPP approach, VIPP approach. The same way
Yes, sir.
we have these kind of triggers which we can follow quite comfortably and make sure we don't miss anything.
One point, small point.
Sir,
What
yes, sir.
we used to follow in our previous software was predominantly a neuro ICU, GCS below 5, 3 for all, absent brainstem reflexes, catastrophic imaging, whatever cause, or a catastrophic EEG for that matter, and non-survivability or futility. If any one of these components was there, it was a trigger for us. And neuro ICUs, neurosurgical ICUs, there should be a tick box that is there a possibility of organ donation so that we can relook at our results, what success rates we have. And this could be driven by the nurses also. At times, the intensivist is preoccupied. He is deluged with so much of information
Yes.
that we lose the track. So there should be a double check on not missing or potential donors. Thank you.
Thank you, sir. Thank you for the crystal clear explanation. And in our, like Jacob sir mentioned, in our hospital, we call the team as Organ Donation and Transplantation Coordination Committee, ODTCC. So you are right, sir. So next question for yes, sir.
Yeah.
Sir, in situations where the family is clinically convinced but emotionally hesitant, how do you balance the empathy with the legal responsibility under the NATO guidances?
It's a difficult situation and it's a very common situation. Most of the time we see this scenario also. So whatever we do, we have to be empathetic and the communication has to be truthful, transparent, well documented, and we have to communicate again and again, again and again. Communication is the key, and empathy will be the holy grail for all this communication. If our communication is lost, we abandon the discussion for whatever cause, we lose the game. So we have to be communicating, we have to be transparent, and at the same time, we have to be empathetic. Although this is a difficult situation, so we have to be utmost careful with whatever word we choose. We have to be gentle in our conversation. Obviously, the family is full of emotions, younger people, younger death. We have to acknowledge emotions, as sir also pointed out in the first phase. They are not accepting. We have to reassure that no decision is being forced and we are following the legal and scientific pathway for such a patient. Second thing, we have to clarify the non-negotiable reality, legal reality gently. Legally brain dead, we have to tell them this is the legal reality and brain death equates to death legally also. So they're not confused. Third important point when they are confused, people have their own anxieties and there are so many myths around brain death and organ donation. We all know that. So we have to educate them at this point. What is their anxiety and what is avoiding them? So we communicate and again and again. Some of them will be bothered about disfigurement. Some of them will be bothered about the religious rights. So we have to involve the right person at the right time so that the family get convinced. Another thing, which is again very important, we have to keep the conversation open. Do not abandon the family at any point. Every potential donor, we have to take it to the logical conclusion. So keep the communication open. It should be but binary. It should not be yes or no. At times, we can harvest only kidneys or liver. Let us go with that. So we have to communicate to the family. Some families will be open to donate one organ or two organs. So we have to accept that. At times, my counseling will fail. I will ask Dr. Jacob or you or Dr. Sunil or some senior person to pitch in at our hospital or our center so that some new style of counseling happens, a new phase comes in and they get convinced. Whatever we do, we have to document thoroughly and we cannot pressurize. At times they say no, so we have to respect that no also. No means no, so we have to give them that autonomy also. This is what we do.
Saurabh, I want to add a little bit here.
Yes, sir. Yes,
to
sir.
what Yash has very nicely, told. One of the key things is trust. If the family trusts your hospital, that you've done everything possible to save the life of their loved ones, then it is much easier for them to take a decision and say yes. Many times the language we use is not right. I've heard almost dead, 95% dead. These are, things we should avoid totally because it should be just dead. It cannot be 95 dead, almost dead. And doctors are talking this language.
Yeah.
That is what leads to a lot of distress in the mind of people. So we have to be very careful with the language which we speak with the relatives. So that's why the confusion comes. But you have to keep the family supported in a decision to donate. You cannot push the family forward, as Yash said very rightly, and it has to be very tired. Takes care of little things, Take
Yeah.
care of water. They may be thirsty. They may not have slept. Take care of those little things. I'll give you one more tip. Initially, when intensivists are talking, they're very hesitant to talk about organ donation. What you can do is ask the relatives whether he was a blood donor, whether they have donated, has there been an eye donation. So sometimes when I started this program way back in 1995 in Ramachandra, my intensivist was not very happy to talk. So we devised a way of breaking the ice. Ask for ice first, we used to say. Would you like to donate the ice? If they said yes to ice, then you graduate to higher level and ask for other organs. And that trick worked. So, many of the intensivists would not ask, but a nurse would ask the relatives, was he a blood donor? Has there been an eye donation in your family? And then they would gauge the sensitivity of how much they are, inclined. Remember, in our country, 40,000 families donate their corneas every year. 40,000, it's not a small number. 26 per million population, that's talked about. Remember that we have close to 30 million blood donations in our country. It's not a small number. 30,000 people donate blood every day in our country. So India is country where giving is very common. That is the dharam, that is our religion to give. Doesn't matter whether it's Hindu, Christian, nothing. Our mind, the Indian mind is to give. Pindadan is to give away everything. Same thing Christians do. Same thing Muslims do. So it is all about giving in our country. Remember that. So you use these small things and then you'll know how the family wants to, whether they will want to give or not.
Yeah, thank you. Yes, sir. Thank you, Shroff, sir. That was an excellent perspective on communication and ethical alignment. So next question is for Shroff, sir. Sir, based on the Indian
I
hospital
thought I'd spoken
experience,
enough, Saurabh.
sir,
I said I
sir,
thought. Tell me, sorry. Keep going.
sir,
Yeah.
sir. So based on the Indian hospital experience, sir, what practical steps can ICU teams take to convert more medically eligible DBD cases into actual donors?
So the first thing is the top management of the hospital should be.
Absolutely.
Organ donation does not happen in this country, not because public don't want to give. It is the processes in the hospital which totally fail to identify, certify, or maintain brain death. I've been saying this for the last 30 years, but now more recently people have started believing it. Donations don't happen because of the hospital's philosophy of not being aligned to our donation. So the first thing, if you want to be a hospital, because 90% of donations happen in private hospitals in this country. So your top management has to believe in our donation and support the ICU. Sometimes, once you declare a brain death, you cannot charge the family any more money. Sometimes, the bill continues to escalate. So those things need to be taken into account. And if the hospital can create a special fund to maintain these brain death patients, because there's a cost to it. And many of those brain deaths will not convert to organ donation. Some of them which gets converted to organ donation, you get paid, you get reimbursement, all that is built in. So, as a hospital, you had to put your procedures in place, your processes in place. I say now that you don't need green corridors on the roads. We need green corridors within the hospital now.
Oh,
We need those processes in the hospital. We need the top management to believe. We need to do those honor walks once there is donation. We need to create a good feel factor within the hospital of our donation. Not something like saying that the donation ho gaya, transplant hua, and they're making money. We need to create that trust. If you do that, our program will fly.
oh.
So the problem is in the hospital domain, not in the public domain, is what we need to remember. I think Jacob will agree with that, and so will Yash.
Yes, sir. Totally, sir.
Agreed, sir.
Totally, sir. Interestingly, sir, I also got the Mohan Organ Foundation card in 96. I was in Chennai those days.
There you are.
Yeah.
When,
So
when
the roots were sown those years.
Yeah, when we started the journey, nobody believed in this journey that
Yes,
this could be possible. It's been but it's been very good journey because we didn't know what is going to happen. But today, everybody at least talks about organization. Our own prime minister has talked about it three
Yeah.
times. So that gives us a lot of this importance to this cause.
Thank you, sir. Extremely valuable inputs from your side, sir. And the last question for Jacob, sir. So, sir, after the brain death, uh, you have already explained many things in your presentation also, but what are the physiological derangements which most threaten the organ viability, and how such intensivists should address these more promptly?
First of all, the understanding the process is important because the change, the waxing and waning, or the sudden fluctuations in the hemodynamics and the vital status, that is something which needs to be considered. And each and every step you anticipate things. It's difficult to predict what happens when it happens. But having said that, it is important to understand the physiological process which I have explained when the spread of the whatever the ischemia comes down, and then act accordingly. Each and every step, I think that's what the checklist, in easy checklist of VIP, which is expanded to VIPP, the ventilation. We have most of the patients will be on ventilator definitely. Your idea is at that time lungs, and then the oxygenation may not be much of a trouble unless there is a devastating cardiac dysfunction with the pulmonary edema sets in. But you need to maintain hydration with the diuresis at that stage and maintain a positive pressure without hurting the lungs much. And then the second thing is that when you talk about severe hypovolemia, hypertension, initial thing will be hypovolemia. So and most of the patients are brain injured patients, and they will have artery lines, everything in place. So it's easy for an intensivist to assess the fluid and see what kind of stage it is there and keep volume status. As Dr. Shroff pointed out, most of the neurosurgery patients will be depleted because of the fact that the cerebral edema is a concern. So we need to change the restoration goals to hydration. Third comes to the cardiac function. Hypothermia, that is a key thing because everything deranges with hypothermia. So a core temperature with a rectal probe or an esophageal probe, and then measures to increase the temperature with whatever gadgets you have used we have in the ICU. The warmers in place should be taken to consideration. And then once it goes to the hemodynamic state, I think if a volume is completely been administered repleted, then give vasopressin. That's the first agent should be started for the vasopressor agent, and it is to 2.4 units per hour. You can definitely give. Then comes the other things, which includes norepinephrine, adrenaline, and other things. Hormone replacement with thyroid and steroids is a key. So based on what kind of pathophysiological problem you are anticipating, you act accordingly. And please understand that certain fluctuations do happen. So take care of that. And moving forward, same like an ICU patient, infections needs to be tackled. You need to maintain a strict. Don't think that it is a potential vented donor. So all infection control practices needs to be controlled, and every infection needs to be ascertained, needs to be identified and treat accordingly, because active infection against can be a problem with regards to the organ donation. So an approach which has got a checklist, and based on the pathophysiological response, act accordingly.
Yeah.
Thank you very much, sir. Any final thoughts
Yeah.
from your side?
If
Yes,
I
sir.
can add,
Sunil
Dr.
sir.
Saurabh, Dr.
Yes.
Jacob has explained very well. We call it the classic triad: hemodynamic compromise, collapse, whatever, vasoplegia, autonomic. Second is endocrine metabolic, and third is hypothermia, acidosis. So we have to avoid these three major things to save the patient and to save the organs. And as we talk, time is money, time is organ while donation also. Many a times this autonomic disturbances or coning is so fast it doesn't give time. We are preparing for physiological stabilization and suddenly patient passes away. So we have to be actually very fast once we identify, and we should be keeping a track of time for all these interventions.
Thank you, sir. Sunil, sir, any final thoughts from your side, sir?
So, I am very happy to see Josh and Jacob in this forum because I think our donation domain truly belongs to the intensive care people.
True, sir.
And my, humble request to ICCM is to take this up as a cause and promote it as much as you can, because this is what is happening in the rest of the world where disease donation is succeeding. I also want to say one more thing, that as clinicians who work in this field, we have a huge responsibility to the society, and we should believe in organ donation ourselves. And we should be carrying out donor cards, and we should be promoting, whenever there's an opportunity to promote donation, we should promote it ourselves. Well, unless you believe it in yourself, you cannot, work for the cause, to be honest. Because, as Khalil Gibran said, you give but little when you give of your possession. You do truly give, you give when you give of yourself. As clinicians, as doctors, we give a lot to the society, not to the patient. When it comes to, something like organ donation, it's a very personal decision. Not everybody would, want to get on that and be aligned to organ donation not necessarily as a clinician. But if you are aligned to the cause and if you believe in the cause, it becomes a lot easier to promote the cause. So my humble request to all clinicians is think about it. So at least if you are not able to be a donor, at least support the cause as much as you can. And that's what I would say. Thank you, Saurabh. Thank you, Jacob. Thank you, Yash.
Thank you, sir.
Great.
Thank you, sir.
Enjoyed
Thank you,
it.
sir. Thank you, sir.
Thank you. Thanks.
Thank you.
So thank you very much, sir. So I extend my heartfelt thanks to Jacob sir, Yash sir, and Sunil Shroff sir for their time, expertise, and commitment to strengthen the DBD program in India. And a warm thank you for all the participants for joining us in this evening. And your engagement is what keeps the EduConnect initiative growing stronger each month. And we look forward to see you again for the next session next month. Until then, stay engaged, stay inspired, and continue contributing to the gift of life. Thank you and good night. Thank you, sir.
Thanks a lot. Good night, everyone.
Merry Christmas and Happy New Year.
Merry Christmas, Dr.
Merry
Jacob.
Christmas, sir.
Happy New Year.
Sunil sir,
Happy New
it's
Year,
a
sir.
real honor to be part of the podium here, to share a stage with you, sir. I'm really, because the history dated back in 2004 when sir was in Ramchandra. I was a DM graduate with Vijayalakshmi Kamath madam.
Yes, I know.
It's so nice to see you, and you're looking so young and energetic as I've seen you.
Where are you working, Jacob? Just for my information.
Sir, Cochin, there's a hospital called the Rajagiri Hospital.
Of course, I know. Of course. Yes, she's of course in Delhi. I know.
No, sir. I am in Lucknow now for last many years. Yeah.
That's it.
Residency.
Saurabh is in Delhi.
Yeah,
Yes,
Saurabh
sir.
is
I'm
in
in Delhi,
Delhi.
sir.
Yash is a close buddy. I think Yash is one of the brilliant minds in our society.
No, you see, it's all teamwork and we learn from each other all passing
Thank you,
days.
Dr. Saurabh. Thank
Hospital,
you.
Lucknow, mein? Yes.
The Regency. This is Regency, Kanpur,
Yes.
Lucknow, and Gorakhpur.
Okay.
Yeah.
Good.
Please visit sometime, sir,
Yeah,
whenever you are free.
just keep connected and let's go forward.
Right, sir. Thank you. Have a good day, everyone.
Thank you, sir. Thank you.
Thank you, Dr. Jacob. Nice meeting
Thank you.
you.
Thank you, Yash.
Bye.